Good morning, ma. Good morning. Take your seat. Are you ready with the case?
Yes, ma'am.
Yes. Start presenting.
So Mrs. X, 37-year-old, residing in Ernakulam, homemaker by profession, complains of heavy menstrual bleeding and dysmenorrhea for the past 1 year. Symptoms have aggravated in the past 6 months. History of presenting illness. Patient was apparently normal 1 year back. Now came with complaints of prolonged heavy menstrual bleeding lasting for around 10 to 12 days. Changes around 6 to 8 pads per day associated with clots and night flooding since the past 6 months. And she gives history of heaviness and discomfort in the lower abdominal pain 3 days prior to the onset of menses, and her pain increases on the first day of menses. It is symptomatically relieved with analgesics. Patient is trying to conceive for the past 2 years. No history of any abdominal distension, but complaints of occasional fullness in the lower abdomen. No history of intermenstrual spotting or discharge per vaginum. Normal bowel bladder habits. No history of recent weight loss or loss of appetite.
So, would you like to ask any other questions to her?
So I would like to ask if she has any breathlessness or fatigue, ma'am. Since she's complaining of such heavy menstrual bleedings with clots, I would like to know if she's having any anemia or...
Okay. Proceed.
Patient consulted at an outside hospital. She was managed with symptomatically with some medications and analgesics. For a brief period of time, her symptoms settled, but now they've resumed back again. So she has come for further management. Menstrual history. Yes. Patient attained menarche at 15 years. Regular cycles previously 1 year back, but for the last 1 year, she's having 10 to 12 days for every 30 to 35 days. And her last menstrual period is on 22nd of January.
So, for the past 1 year, she's having symptoms.
She's having symptoms for the past 1 year. 6 months, the symptoms have aggravated. Obstetric history, spontaneously conceived 1 year after marriage and 1 normal vaginal delivery 8 years back. Intra and postpartum periods were completely uneventful. Patient did not use any contraception post-delivery. Male baby weighing around 3.2 kg. Medical history, no history of any systemic illnesses or bleeding disorders in the family. Surgical history,
Is she on any medications?
No, ma'am. She initially took medications to relieve pain and bleeding. Now she is not on any medications. Okay. Surgical history, no history of previous surgical interventions or blood transfusions. And family history, mother had underwent hysterectomy in view of fibroids. Personal history, normal bowel bladder habits and normal sleep and appetite.
Okay. So, from the history, what do you think the cause of her bleeding could be?
The cause of bleeding could be any uterine pathology, ma'am. So, it can
what
be
uterine pathology you think about?
Like leiomyoma or adenomyosis, or it unlikely to be a cervical or an endometrial polyp.
Okay.
Because she's complaining of such heavy bleeding with clots and breathlessness.
Okay. Did you examine her?
No, ma'am. I would like to proceed with the further examination. So, first, I'll have to ask the patient to empty the bladder and consent has to be taken, adequate exposure. Patient is alert, conscious, moderately built, and weight is 62 kg, height is 158, a BMI of 24, a pallor is present. Mild pedal edema is noted, breast and thyroid normal. On inspection, abdomen shape and size normal, umbilicus central and everted, stria present, no scars and hernial orifices are free. Lower abdomen, slight fullness is noted in the subumbilical region. On palpation, it is soft, non-tender, a mass of around 16 weeks from the lower hypogastric region towards the subumbilical region and the right iliac fossa. It is bossy. It has a bossy surface, irregular borders, and the lower pole is not palpable.
What about the mobility?
Transversely it is mobile, vertically it is immobile. Okay. On auscultation, bowel sounds were heard, and systemic examination, CVS, S1, S2 heard, no murmurs, and RS bilateral air entry present.
Can you summarize?
Okay. So 37-year-old, P1L1, 1 normal delivery, LCB 8 years back with complaints of heavy menstrual bleeding and dysmenorrhea, aggravated symptoms in the past 6 months. And with breathlessness also. The patient is also having secondary infertility, and on examination I found around 16 weeks, mass of 16 weeks.
Okay, what do you think the cause could be?
So from after doing the examination, it could most likely be a leiomyoma, uterine pathology, because heavy bleeding with clots and such a huge mass, and also secondary infertility is pointing out towards leiomyoma. Other differential diagnosis I would like to give is adenomyosis. Or it can be a cervical polyp or an endometrial polyp as well. So further,
Why did you put leiomyoma as the first diagnosis for this patient?
okay, since she belongs to that reproductive age group, and it is more common in the reproductive age group. It's a estrogen sensitive tumor. So that is why. And also her symptoms like heavy bleeding and dysmenorrhea.
So she's having heavy bleeding
and
secondary infertility, dysmenorrhea, and there is a mass in the lower abdomen. Okay. So how will you further evaluate her?
I would further like to do a per speculum examination and a bimanual examination. So per speculum examination, I would want to rule out any local causes, like if there is any cervical erosion or a cervical polyp. I would also like to take a pap smear.
Okay.
And on bimanual examination, I would like to assess the uterine size and mobility.
Okay.
And also I would like to do an endometrial sampling because she's having such heavy menstrual bleeding. I want to rule out the endometrial causes as well.
Okay. So what investigation would you like to do to confirm your diagnosis?
So to confirm the diagnosis, I would want to do a pelvic imaging. So it is a transvaginal ultrasound. So that will be my first line of investigation.
So will you be able to identify the fibroid and adenomyosis by ultrasound?
So in ultrasound, if it is a fibroid, there's going to be a hypoechoic, a well-defined lesion with some
because it is compressing the myometrium. Okay.
So it has a peripheral vascularity. If it is an adenomyosis, it's going to be an inhomogeneous diffuse appearance with a sun ray pattern, and so that's how I'll differentiate.
Okay. Suppose it is a fibroid. Can you tell me the classification of fibroid?
Classification of fibroid in general, it would be subserosal, intramural, or submucosal. It can be there can be a cervical fibroid or a broad ligament fibroid or
any
parasitic.
other way of classifying?
In other way is a FIGO classification. In FIGO classification, I'll divide it into two. First is submucosal and the second is others. In submucosal, the first one is intracavitary and it is pedunculated in the cavity, and the second one is in the myometrium. So it's going into intramural. So it's less than 50% intramural, and third category is more than 50% intramural.
So this patient has presented with menorrhagia and dysmenorrhea and also infertility. Do you think in what way the fibroid can contribute to menorrhagia and dysmenorrhea? In what way it can cause it?
So fibroid is usually there is an increased vascularity and there is increased uterine surface area, and also increased prostaglandins and decreased myometrial contractility. So all of this is going to result in menorrhagia and dysmenorrhea.
Okay. And what is the cause of infertility? In what way it contributes to infertility?
So the cause of infertility is because in the fibroid uterus is usually enlarged, so it takes a long distance for the gamete transport to happen, and if there is an implantation on this fibroid, it can result in miscarriages and also decreased motility of the tubes, and cervical fibroid will cause impaired sperm transport as well inside.
So there is a mechanical block with cervical fibroid and also a fibroid near to the corner of the uterus, a tubal block. Okay. So does all fibroid require treatment?
Not all fibroids require treatment, but if the patient is symptomatic, then the treatment has to be provided, and all asymptomatic fibroids, if it is more than 12 weeks, we have to treat, and rapidly growing fibroids have to be treated, and if they're going to cause pressure symptoms like bowel or bladder symptoms, it has to be treated. Apart from that, if it is heavy menstrual bleeding, anemia, and patient is planning for pregnancy,
so symptomatic fibroid has to be treated.
Yes.
Okay. So after the ultrasound, suppose the patient comes with a report to you and that shows a 8 centimeter type 3 myoma compressing the endometrium, and another one, suppose it's a 4 centimeter subserosal fibroid. So what treatment options? In general, what treatment options you discuss with her?
So for this particular patient, since the patient is trying to conceive, after ruling out all the other causes of infertility and also male factor analysis, semen analysis, after I finish that, I would like to counsel her for myomectomy. So when I counsel her for myomectomy, I'll also...
So what are the important points that has to be mentioned?
So when I counsel her for myomectomy, I'll have to tell her that this fibroid can recur again, and also the fertility cannot be completely assured, and there can be hemorrhage, and there can be like profuse bleeding, and warranting even hysterectomy. So adequate blood arrangements have to be made. And
so what are the complications suppose a patient agrees for hysterectomy, and what are the complications you anticipate during the surgery?
So during the surgery, there can intraoperatively there can be heavy bleeding and requiring blood transfusions and even need for hysterectomy. Post-operatively, there can be infections, or there can be uterine additions.
Okay, so and also injury to the
surrounding structures like bowel and bladder.
Okay. So you told bleeding is a major problem during the surgery. So can you reduce the bleeding? Any measures can be taken to reduce the bleeding in surgery?
So preoperatively, I can give leuprolide for 3 months. This not only reduces the size, but also it reduces the bleeding, and it also improves the...
So that causes amenorrhea.
Yeah, it suppresses the period. So after giving leuprolide, we can take up the patient. So even it reduces, like if the fibroid could not be done as a laparoscopic and it had to be done open, after giving leuprolide, since the size is reduced, we can take her up for laparoscopy itself. Intraoperatively, vasopressin.
So when will you plan the surgery?
After 3 months of leuprolide.
Okay, at what phase of menstrual cycle?
It's usually done post-ovulatory and pre-menstrual.
Post-menstrual
and
pre-menstruation.
Post-menstrual and pre-ovulatory stage, when there is a decreased, will cause decreased bleeding. So at that phase, or intraoperatively, I would like to give vasopressin to reduce the bleeding, and also tourniquet could be tried around the umbilical artery.
So adequate blood also has to be arranged for that. Okay. So after your successful surgery, she becomes pregnant. And what are the complications you anticipate after a myomectomy? Pregnancy after a myomectomy.
So the placental adherence can vary. So there can be improper placentation, and then there can be scar rupture or uterine rupture.
When she gets into labor, they can. So this patient, you told she has delivered vaginally 8 years back, normal delivery. And would you like to keep her for vaginal delivery?
I would like to keep her for vaginal delivery if the cavity has not been entered during myomectomy, and I have to counsel her regarding the complications that can occur. If the cavity has entered, then we should not keep her for the vaginal delivery.
Suppose she says to you that she will decide upon the myomectomy, but after 3 months she comes with a positive urine pregnancy test, surprisingly. So what are the problems you worry about?
So in pregnancy, fibroids will tend to grow in size because of increased vascularity and hormones. So the most common degeneration is red degeneration that can happen. So when red degeneration happens, because it's growing in size, but there is not enough blood to supply it, so it's undergoing ischemia and necrosis. So this can cause severe pain and nausea and vomiting, warranting hospital admissions, and it is conservatively treated with painkillers and
test. And what are the effects of pregnancy on this fibroid?
So in pregnancy, we can divide it into maternal and fetal complications. So maternal, if the implantation is going to happen on the fibroid, it can result in miscarriages. And in first trimester, recurrent miscarriages can be the problem. In second trimester, abnormal placentation can be the issue because of the fibroid mass occupying. And
what are placental problems can occur?
So there can be placenta previa. If there is a retroplacental fibroid, then it can result in abruption also. In third trimester, there can be intrauterine growth restriction, fetal malpresentations like breech and all. It increases the chances of cesarean section for the mother, and also obstructed labor because the myometrium is not going to contract, decreased contractility. Apart from these two, postpartum, there can be postpartum hemorrhage and requiring even blood transfusions.
So preterm labor also can happen. And after delivery, the involution of uterus may not be proper. Okay. So what are the general indications of hysterectomy in a case of fibroid?
Hysterectomy in case if the symptoms are not resolving with all the lines of management and patient doesn't wish to retain a reproductive or menstrual functions, hysterectomy can be done. Rapidly growing fibroids and fibroids with pressure symptoms, and at post 50 years a prophylactic oophorectomy can also be done.
Okay, so can you mention about some of the newer modalities of treatment? Suppose a patient declines or denies the hysterectomy or surgery. The symptomatic treatment of fibroid.
Symptomatic treatment of fibroid depends. It has to be individualized for a patient. In case if the patient, it should depend upon the age of the patient, menstrual complaints, and severity of the symptoms. So if the patient is going to be belonging to a phase where she doesn't wants to get pregnant in any of the recent times, then the first line of drug will be an oral contraceptive pills, estrogen and progesterone containing pills. They're highly effective because they reduce the heavy menstrual bleeding, and also they're used as contraception, and anemia might also get resolved. In case if there is any contraindications to OC pills like CV or increased risk of thrombosis, then the second line would be a progesterone containing intrauterine devices which contains levonorgestrel.
Will you be able to put this device for this patient?
For this patient, she wants to get pregnant now. She's trying for conception, so we cannot put this.
It is a type 3 myoma compressing the myometrium. So do you think it will hold or be effective?
No, it will not be effective.
It's a huge uterus, right?
Huge uterus. And again, submucous type of myoma also, we will not be able to put it.
Okay.
And third line of that's total contraindication for hormonal treatment, then we can give tranexamic acid, which is an antifibrinolytic, which minimizes the bleeding. The second line of drugs is that if this is not going to get control, the second line of drugs would be to give GnRH analogs, which is like leuprolide. As mentioned earlier, it can be given preoperatively as well. So leuprolide is given monthly once for up to 6 months. It causes menstrual suppression and bleeding is reduced, and anemia might also get resolved. The third line of drugs, third line of management would be surgical management, either myomectomy or hysterectomy.
That we have discussed already. Okay, so any newer modalities of treatment for those patients who are not willing for surgery?
Newer modalities will be mifepristone, 200 mg, or we can give ulipristal.
Not 200, 25 milligram.
25.
Yeah, these are all experimental only. Okay. Any other measures to conserve? You trying conservative measures for management? Any radiology based procedures?
Newer modalities like we can do ultrasound guided ablation or magnetic resonance frequency guided ultrasound ablation or uterine artery embolization. If the size of myoma is less than 5 centimeters, we can do a hysteroscopic resection as.
Suppose you are doing myomectomy. What are the routes through which you can remove a myoma?
Depends on the size of myoma. It can be either an open myomectomy or a laparoscopic myomectomy. To reduce the size is why we give a preoperative leuprolide.
Suppose you find a type 0, 2 centimeter myoma. What will be the preferred route of removal?
It will be a laparoscopic.
It is a submucous myoma.
So it's a hysteroscopic resection we can do. It's only 2 centimeters.
Okay. So that was the last question.
Thank you.
Thank you.
Is used for classifying myomas. There are 2 types, submucous type and others. So in submucous type, 0 is intracavitary and submucous. 1 is less than 50% in myometrium, more into the cavity, as you can see, and in 2 it is more than 50% into myometrium. 3 is it is inside the myometrium and it is touching this endometrial cavity. 4th is it is completely inside the myometrium, so it's intramural. And 5th is it is less than 50% in subserosal, more into the myometrium. And 6th is more than 50% subserosal. And 7th is pedunculated subserosal. 8 is others like parasitic broad ligament fibroids. So this is the FIGO classification.